Well, welcome everyone. It's a pleasure to be here today. My name is Cindy Lemire, and as Chris just mentioned, I'm a scientist at the Brigham and Women's Hospital and a professor of neurology at Harvard Medical School. And today with me I have...
I'm Tazeen Ahmad. I'm one of the biotech analysts at Bank of America. We're happy to be here with you all in Boston. And we're going to have, I think, a fruitful discussion over the next 40 minutes or so. And so I think we can just throw it straight to Q&A. And I'll turn it back over to you, Cynthia.
Okay. And I think we're going to just quick do an introduction of our panelists. So please, Joe.
Good morning. I'm Jo Viney, co-founder and CEO of Seismic Therapeutic, a machine learning immunology company focused on autoimmunity.
Hi, I'm Jeff Wilkins. I'm the Chief Medical Officer of Abcuro. We're in phase 3 in inclusion body myositis and studying inflammation with a KLRG1 T-cell specific depleter.
And I'm Niranjana Nagarajan. I'm an entrepreneur in residence at MGB Ventures, working on building a new company for therapeutics and autoimmune diseases.
Great, thank you very much. So the title of this session is The Disruptors, the role of pathway inhibition in inflammation and inflammatory diseases. And so we're going to really make this as broad a discussion as possible. So first of all, to start out, it seems that the immune system is very important from head to toe. And so one of the first questions is to ask, do you believe, as panelists, do you believe that the immune system is a master regulator in the human body and in disease as well? And what are the different systems affected by the immune system? So,
Sure, I'd be happy to start. So it's been really interesting. I started my career as a mucosal immunologist a number of years ago. And I think at that time, immunology was probably not a very well known discipline, particularly with the general public. But we've seen over the last 2 or 3 decades a real interest in how the immune system plays, not just in protecting our bodies from infection, but in driving much of the autoimmune diseases that we think of regularly, you know, lupus, asthma, inflammatory bowel disease. But more recently, we've seen even more involvement of the immune system in cardiometabolic disorders, in neurological disorders. And so I think there's a greater understanding of the role that immune cells and immune mediators can play in driving many different diseases that affect the body. I think that it's been really interesting. The pandemic, the COVID pandemic, really helped the general public understand even more about what the immune system can do. And so it's been really fascinating that now, for the first time, I can actually talk to family members and they understand a little bit about what an antibody is and what an immune cell is and how it protects the body. So it's been really interesting to see. I think we still need to work on convincing the general population about the role of the immune system beyond infectious disease and the role that it plays not just in autoimmunity but in many other disorders. So that's, I think, what's changed in the landscape over the past couple of decades or so.
Yeah, no, I agree with Joe. As a clinician in practice before coming into industry, you know, it was thought that obesity was obesity and heart disease was heart disease. And now it's clear that obesity is very pro-inflammatory, and insulin is endogenous insulin and exogenous insulin is pro-inflammatory. A lot of the things we look at with infections, you know, whether chlamydial infections in the mouth play a role in cardiovascular disease, as well as others. We were just talking, Cindy and I were just talking about the inflammatory disease in Alzheimer's disease. So those things that were once thought of as having certain pathophysiologies and underlying pathophysiologies are actually where inflammation plays a major role in driving change and progression, as well as ultimately pro-fibrotic and destruction of the cells.
And I completely agree with both Joe and Jeff. And I would only add that there's, I think, also a role for the immune system in traveling and communicating between different parts of the body. It is probably the most mobile system, if you will. Most of the blood are immune cells. And there's a very important role that we're all starting to appreciate that the immune system plays in communicating between other systems of the body as well.
Would you like to answer as well? It's up to you.
I'm just moderating. I want to hear
Okay.
your
Okay. Great. Okay. So the next question is really looking at how immunology and drug development targeting immunology has changed over the past few years or even decades. And whereas it used to be a much broader drug development, such as using, for example, steroids, something like that, now it seems that both with newer technologies and newer targets, that it's much more exquisitely focused either on specific cell types or on different pathways. So could you please comment on how you see this change evolving and where you think we are now?
So that I don't answer everything first, why don't we take it in turns? Do you want to go first?
Thank you. You know, when in medical school, 80 years ago, whenever I went, there was, we didn't know cytokines. And so the initial work that was done by a lot of the early monoclonal antibodies were to try to target effects and inhibition of cytokines, whereas before we were just using big hammers like methotrexate, cyclosporin, and corticosteroids. What's interesting now is that my belief is that unless there's a cytokine, for example, like IL-5, which is just specific for eosinophilic inflammation and proliferation, it's really, I think, the ability to deplete cells and be very specific in depleting cells, either with depleting antibodies or bispecific antibodies or CAR-T is really, I think, where the future is going. And I think the specificity of that is really where you can have a greater impact and also be safer in that you can target the ability to deplete those cells.
I think we're in an age of progress in immunology. So tech has the model of Moore's law, right? That in every 10 years or so, you miniaturize the size of a chip reduces to the point. I think we're in the opposite phase in immunology. The technological developments we've been seeing have just been expanding the scope and the range of all the things that we can do. If you think, I think the first CRISPR papers came out maybe in 2012 or something like that, right? I mean, that's not that long ago. And we're at the point where we can now deploy those novel technologies in therapeutics. And so what we can, given the complexity of the immune system and the multiple roles it plays, particularly in autoimmune disease, I think we now have so many tools that will allow us to access many different therapeutic paradigms that may not have been even conceptually possible 20 years ago.
Yeah, I think it's been really, as the other panelists have just mentioned, we've seen a dramatic advance in how we treat a disease, particularly autoimmunity. When I started my career, we were very excited in antibodies that blocked cytokines or cytokine receptors. So that was late 90s, early 2000s. And we've seen progress since then in now either targeting cytokines to specific locations or specific cells, or depleting cytokines from specific locations and specific cells. So local immune modulation is a much more exquisite way of trying to control the immune response rather than that global immune suppression that Cindy was talking about that we saw with steroids. I think now we're entering an era with many different modalities on hand. I think we have the ability with heterobifunctional small molecules to target particular cell types and inhibit them. With the protein-targeted degraders, we have the ability with bifunctional antibodies now to either direct a molecule to a certain location on a cell or a certain part of the body, and actually drive effector function that is mediated by bringing two cells together. So I think it's a very exciting time that we're entering. There is a lot of activity in this space that will allow us to now much more exquisitely treat where the inflammation is, rather than necessarily suppress the immune system throughout the whole body. So it's an exciting time to be here, and with many new new modalities still coming into play. I think Jeff, you mentioned about the cell depletion. I think that's something that has garnered a huge amount of interest, particularly in the autoimmune disease space in the last 6 to 12 months, where we've seen the ability to deplete certain cell types. And I think this is a tremendous asset for treating patients with severe or advanced diseases that perhaps have not been able to respond to some of the milder approaches. So exciting times ahead.
So I maybe wanted to ask a question regarding all of the options that are currently on the table. Perhaps there's more options than ever before. So how do you kind of weed through all of the information to figure out, you know, disease-wise, what might be best, therapeutics-wise, what might be best, modality-wise, what might be best, and are you using AI at all in this process? And if so, can you talk about that?
Okay, I'll start and then we'll pass it to you. I think the answer to that question, first and foremost, is that biology will drive that. Right? I mean, I think the advantage of having so many tools and modalities at our disposal is that we could actually use biology to determine what is the appropriate way to approach a certain disease. For example, Joe mentioned the depletion of cells in severe and refractory disease. That's a wonderful option for patients who might not have had another option, right? But the ability, maybe that is not the appropriate technology for someone who's at a different stage of disease. Mm-hmm. And one might consider then, given the constraints of where they are, if it's a similar pathway, is there a different agent? Is that more appropriate for a small molecule or an antibody, for example? And certainly as diseases progress through stages, that they're going through, different biological pathways become relevant. And so then the appropriate use of the appropriate targets and the appropriate modalities at those stages is also a very important part of this treatment paradigm.
Yeah, so I think we're definitely in an era where artificial intelligence and machine learning can help us. And I think it's important to break down AI into the different ways that it can be used. So one is in patient stratification. There is a lot of effort in terms of using AI to look through medical records to help predict whether susceptibility to disease or likelihood to respond. That's really with patients, and I think that's going to be very valuable to direct the right medicines to the right patients. There's also the ability to use artificial intelligence to map out targets and pathways. As Niranjana just mentioned, we still don't have a full understanding of disease, and we don't yet have the ability to treat every disease to a cure. And I think that the use of artificial intelligence to help us dissect the pathways that are involved in the disease process is going to help identify new targets. With regards to the modality that we use, a lot of that is driven by where do you want to target. So if the molecule is a soluble mediator, a biologic can work well, or a small molecule to disrupt the signaling pathway can work well. I think that we've seen the advent of antisense oligos, and I mentioned the PROTACs as well. These are different ways of targeting cells that really help drive to the pathway of mediators in disease, whether it's cell type or soluble mediators. But there are also other ways to use artificial intelligence, and I think we'll get to this a little bit later. At Seismic, we're using machine learning to help us with our protein engineering. So we've used our knowledge to help understand the disease process. We've used our knowledge to think about what cells and pathways are involved in that disease process, and we want to make a better protein or a better therapeutic. And so the way we're using machine learning and artificial intelligence specifically at Seismic is to learn from nature. So we build training models based on natural proteins to help us understand how one protein interacts with another protein, and we can use that to then drive how we engineer our molecules, how we make amino acid substitutions to get the activity that we want, whether we want higher affinity molecules, lower affinity molecules, whether we want to invisibilize the molecule to the immune system so that we can use it as a therapeutic. So I think it's, AI covers a broad swath of different approaches, and I think we're at a very exciting time. In academia and in industry, we're seeing many new algorithms and models coming into the public domain. I think, I'll just remind everyone, we didn't have ChatGPT just 3 or 4 years ago, and I don't know how many of you are using it, but it's a tremendous advance in helping us use this artificial intelligence to help predict or guide where we should go, what direction we should go. And much like ChatGPT can compose paragraphs and letters and writing complaints to whoever you want to, we can use similar models based on protein training models to help us drive where we want our proteins to be so that we can make better therapeutics.
That's great.
Just a corollary, I know nothing about AI. It would be an imposter syndrome to comment, but I do want to make a corollary mention of the regulatory environment. As Joe had said, it helps identify certain patients. There's one division that's so far out in front of identifying patients and using biomarkers or specific patient phenotypes to determine a certain therapy and correlate effects of or efficacy for that therapy, and that's the oncology division. The other divisions are not there yet, and it's really, I think, it's something that the FDA is going to really have to adjust to as we get better at defining patients, and specifically defining specific biomarkers, either circulating biomarkers or tissue biomarkers, as to which patients are more likely to respond to certain therapies. And I think that's going to be an important thing as we see more ability to choose specific patients and choose specific treatments for these patients.
Maybe sticking to modalities, I did want to ask about how you think about chronic therapy versus potential cures for immune-mediated diseases. Do you think that that's practical for certain diseases to have a functional cure, maybe not a one-and-done for forever treatment, but a very infrequently delivered treatment? Is that part of the line of options that a company would be looking to, or is it simply just trying to get the best chronically delivered therapy?
Yeah, I think it's important to think about the risk-benefit ratio with any therapeutic approach. And there's a spectrum of severity with the majority of autoimmune diseases. So hazarding a guess, there are many people in this audience with an autoimmune disease or a family member with autoimmune disease. And for some patients, a regular therapy that is beneficial and doesn't have much risk can be a great way to sort of restore normal living with a normal immune system with a little bit of modulation. But for those patients where there is a significant disease or severe disease, particularly a disease where it's hard to get out of the relapse and hard to get into remission, I think we do need to think about better intervention approaches. And I think I mentioned in a comment a few moments ago, we're seeing a lot, and I think, Jeff, you'll probably talk about this, about using cell depletion as a way to reset the immune system. So I think that as researchers, as people who work in the drug discovery and development industry, our ultimate goal is to restore normal immune homeostasis to every individual with a dysregulated immune system. But there's many different ways to do it, and that really depends on how significant the intervention has to be. I think in an ideal world, we all are driving towards a cure, but I think one does have to think about the risk-benefit ratio with any type of intervention. Jeff, I don't know what your thought is on this.
Yeah, I think a lot depends on the underlying pathophysiology. Whatever the driver of inflammation is going to really determine how possible like a cure is. And I think with that, to Joe's point, the whole goal is to try to optimize the risk to benefit profile toward that. So just an example, and I just want to give a shout out to Stephen Greenberg. He's a neurologist at MGH, who's really our disruptor at Epicuro. He was the one who discovered the antibody after years of frustration of treating patients with inclusion body myositis for which there was no therapy. You know, steroids didn't help, methotrexate didn't help, cyclosporins didn't help, anti-TNFs didn't help. And so what he did was use computational biology to determine that there are certain cell type that was likely the underlying cause of the disease based on the infiltration of that cell type and the destruction of myofibers, muscle myofibers. To that end, we don't know what the ultimate driver of that inflammation is and what those are. We do know that the pharmacodynamic effects of the antibody are longer than the pharmacokinetic effects, which is good. The problem is that until we understand the underlying pathophysiology and the cause, that causality, it's going to be difficult to have cures for treatments or cures for diseases that we just don't quite understand. We know why they have inflammation, but we don't understand what the ultimate driver is.
Yeah, and I mean, I agree as well. I think while a cure is, of course, the goal for anyone who's developing a drug, some of it will be influenced by the level of severity of the disease. If you have a raging 6-alarm house fire, maybe your first impulse is to dampen the flames, right? Whereas your approach, when something is earlier in the process, you might try to completely stamp it out. And you may be able to, whereas you may not be able to when it's further out. And I think when we think about clinical development of therapies for autoimmune diseases, I think a staged approach where you can start to see effects on the immune system, so immunological metrics of activity, followed by metrics of disease activity, and then tracking the paths to eventual resolution, restoring, of course, the patient's quality of life wherever possible. I think these all play into how we think about therapeutics and their effects on patients.
And maybe on that point, on cell therapies, there's a big effort by companies who might have looked at, again, we talked about it a couple minutes ago, CAR Ts, NK cells, efforts that were originally placed in oncology, maybe also now shifting or adding autoimmune-related diseases. What are your thoughts on read-through ability from what results we're seeing from oncology studies, if at all, to immune-based therapies? And how do you think about the safety profiles of those drugs as being tolerable for potentially different set of patients with different needs?
That's you. I think that's you.
Okay.
Yeah.
So I think there's certain places where the oncology paradigm translates very well to autoimmunity for cell therapies. And of course, the CD19 CAR T cells are a great example, right? And I will say that there are some, when your cells are very good at, CAR Ts are very good at killing what they're directed against. And when your therapeutic model is that I want to go in there and kill that lymphoma, you have a very tractable way of approaching it, you can quantify it, and you can see when it works. Similarly, it appears in autoimmune diseases where B cells are the underlying cause, you can follow a similar process where you use the CAR T, it depletes the B cells, and you see the transformative efficacy that we've been seeing with lupus, et cetera. How that expands to other diseases where that the source is less clearly defined is going to be an open question, I think, in the field. I think there's robust activity in certainly trying to, you mentioned other cell types. Of course, Tregs have to be part of that conversation and how Treg cell therapies, and there's going to be a subsequent session where we're going to talk about cell therapies, of course. And I think, there's a lot of reason to believe that cells have access to tissues and cells have access. When you put in a single molecule, hypothetically, you're saying that I am working with a single pathway. When you put in a cell, what you're doing is you're giving that cell, the therapeutic, has many different ways it could work. And you're not picking that I will just use this inhibitory pathway necessarily. My Treg, as an example, could go in and do a number of different things. And that is the potential of cell therapy. And I think we have to, I'm eagerly awaiting all the clinical studies to see how that plays out. So I think some of the learnings from oncology translate very well when you're talking about depleting a very specific source or cause. The further dimensions of how cell therapy will operate in autoimmune disease is a very active area, and I think there's a number of different companies trying very creative solutions, and I think at the end that's the path to new therapies for patients.
Yeah, I could say it's been really exciting. for autoimmune disease patients or physicians prescribing treatments for autoimmune disease patients, the advances that we've seen in the last 12 to 18 months with this transition of both the CAR T approaches for cell killing or the T-cell engagers for cell killing, making a move from the oncology space into the autoimmune disease space. I think that one of the challenges with T-cell engagers, particularly in the oncology space, has been cytokine release syndrome, or the elaboration of many pro-inflammatory cytokines associated with cell killing. But that's thought to not be so much of a problem in the autoimmune disease space, where the target load is less than in the oncology space. But I think it's something that we're going to still keep an eye on. I think that if in a situation where there is significant disease, as we talked about earlier, severe disease that's refractory to other approaches, I think resetting the immune system by taking out the drivers of disease, and in most cases this is B cells that are driving antibody-mediated diseases, this is a great way to sort of hit reset and allow a patient to sort of redevelop a normal immune system. But I think that this is not going to be a frontline treatment in the near term, because it is a significant risk benefit ratio that is more on the risk side to remove all B cells. There are other approaches that are being evaluated for antibody-mediated diseases. Right now, we've seen a huge amount of interest in companies like argenx and Immunovant with approaches for removing antibodies, the tissue-damaging pathogenic mechanism of antibody-mediated diseases, removing those antibodies with the FcRn inhibitors. So if you block the recycling of antibodies, these antibodies get cleared. And that's perhaps a way that is less of a sledgehammer. Rather than getting rid of all B cells and all antibody isotypes, if you can get rid of IgG, which are some of the main drivers of disease, you can leave the other Ig molecules that you need to protect your mucosal surfaces, for example, IgA. Those mediators are still intact, providing some protection, and it's just a little bit of a gradation. So I think that this gets back to really assessing the severity of disease, and on one end we have mild or moderate approaches to treating disease, and I think on the other end, for refractory disease, we are going to need these cell depleters to really potentially help those patients who just are not responding to other approaches.
Yeah, nothing to add. They're wonderful.
Maybe on the point that you make about for refractory patients, given the consistency of B-cell depletion, there are companies looking to do just that with maybe infrequently dosed treatments. But based on what you said, it seems like there's still some wood that needs to be chopped on that front for it to potentially become a modality that's applicable across the board for patients that are not necessarily as advanced. Is that right?
Yeah, I think that that's true. You know, I have to be careful here. I don't treat real patients. I'm a PhD, not an MD, but I think that as a person who has an immune system, and I've studied the immune system for many years, I think to take out an important cell type, like a B cell, for a long period of time, yes, the therapy is infrequent. It may be every 6 months, but once you've depleted the B cells, it takes 2 to 3 months for B cells to come back. And as we know, in the pandemic, we all needed an active immune system. We all went and got vaccinated, or at least I hope everyone went and got vaccinated. And we needed our B cells to make those anti-COVID antibodies. So in severe disease, where those B cells are making antibodies that target the body, yes, you want to remove those B cells. But if there's another pandemic or another infection that comes along, you actually want some of those antibodies or B cells to help protect you. So I think that's where we have to think about what the risk-benefit ratio is of leaving individuals without a significant arm, the humoral immune system arm of their immune system, for long periods of time. So it's great if you don't have other options, but I don't think yet we're going to be at the stage where depleting B cells is routine for all autoimmune diseases.
I was just going to say, and one of the problems just clinically is that a disease that's inflammatory in your 20s might be fibrotic in your 40s. You know, asthma is one. The inflammatory bowel disease, often with patients will progress to needing a colectomy with ulcerative colitis because of cancer risk. So one of the things with recalcitrant diseases or resistant diseases is that we have to have a way to be able to assess treatment of the inflammation while it's still inflammation and before it gets to be where it's fibrotic, or in the case of inclusion bytomyositis, the muscle fibers are actually replaced by fibrofatty tissue. So again, I think it's key that when we're talking about inflammation is to capture it when it is inflammatory and not when it's progressed to fibrotic change.
Yeah. I agree with what Jeff and Jeff said.
Okay. One more question from me. I'll turn it back to Cynthia after this. I wanted to ask you about the idea of neuroinflammation. And so how does that complicate things in terms of drug development? Why is that something that you would want to pay attention to make sure you have the most ideal drug profile?
The first part of the question?
Neuroinflammation, is that an area of concern for drug developers?
So, yes. The short answer. It's one that is, as we understand it better, but it's clearly something that whether it's central or peripheral, and again, what the underlying pathophysiology is and how it is impacted by the treatment of the specific disease. It's critical, and I think that again, it's an area that we're very interested in, and that it's critical that we continue to understand what that underlying pathophysiology is.
Yeah, and I'll just say briefly that I think with neuroinflammation from a drug developer standpoint, local inflammation in the CNS is very difficult to reach, and so that I think those mechanisms are important in a number of diseases, and how we develop therapies that can actually reach and mitigate some of that inflammation is quite a challenge. And Cindy, I don't know, this is definitely your area as well. It'd be lovely to hear from you. From some of
Yeah,
this.
I think there are very strong challenges in neuroinflammation, and for many decades it was not thought to be a contributor to, a big main contributor to neurologic diseases, and now there's a resurgence in importance of inflammation, neuroinflammation, and immunity, both adaptive and innate immunity. So I think one of the important things is to realize that there's crosstalk between peripheral and CNS inflammation. There's a drug delivery issue, but in many of these neurologic diseases, there is disruption of the blood-brain barrier. So in that case, it might actually be a benefit that you have a better chance of delivering drugs. But I think this is a huge area that's growing very, very rapidly right now.
Yeah, I think we've, for many years we've thought about neurological diseases like multiple sclerosis as having an immune component. We've had approaches that target the immune system in the periphery, and we've had more of a challenge getting immune modulators across the blood-brain barrier, given that there's some leakage when there's inflammation in the brain. We've sort of thought about just small amounts of antibody might be enough to cross the blood-brain barrier. But I think that, to your point, Cindy, we've got now a greater appreciation of the immune system in neurodegenerative diseases that we didn't have previously. I think, a number of years ago, we really approached the neurodegenerative diseases like Parkinson's and Alzheimer's as being something that was wrong with the neurons in the brain. And now we're understanding that actually there is this crosstalk. There are many soluble mediators and cell-cell interactions that occur between components of the immune system and the neurological system that drive some of these diseases. And I think that we have to overcome the challenges of how to get some of these therapies across the blood-brain barrier if we need local modulation. But we're at an exciting time where there are some approaches now using oligonucleotides, for example, that can actually reach or penetrate regions of the neurological system that protein therapeutics, for example, just cannot get to. We've had a lot of interest in small molecules. I think now we have the ability to think about how to generate a small molecule with the attributes that can either cross the blood-brain barrier or not cross the blood-brain barrier, which gives us some optionality. And I think it's going to be an exciting decade as we move into this new era of approaching neurological disorders with immune modulators.
It just goes to show the immune system is the master regulator, right?
And I think I just wanted to follow up quickly. I think that, there are modalities, new methods for getting more drugs into brain, such as shuttle programs, transferrin shuttles, for example, to get more antibody into the brain. And there's also focused ultrasound, which transiently opens the blood-brain barrier. So I do think there's hope. One of the things I'd like to ask the panel about now is the role of precision medicine and target identification. I know those are two separate things, but we're learning much more about genetics and GWAS hits and proteomics, transcriptomics, all of that. How do you see moving the field forward in terms of target identification for a specific person with a specific, let's say autoimmune disease, who also has the complexity of being an individual human being?
Yep, I can't remember whose turn it is, so
I'll
start. So I think that we can use precision medicine. I think we can use genetics to help localize where in an inflammatory pathway there might be a contribution to disease. But I think it's important for autoimmunity in particular. Most of these autoimmune diseases are polygenic, so there isn't a single contributor. There are many different genetic mutations that can lead to inflammation in an organ. And I think that's a little bit different perhaps than some of the neurological or neurodegenerative disorders, where we are seeing much more precision around single gene deletions or mutations that drive the disease process. So I think it's going to be a challenge, but I do think we can use precision medicine and genetics to help guide us into the vicinity of which cells and which pathways we might want to think about developing therapies for. But because because most autoimmune diseases are polygenic, there are different segments of patients. And I think one of the things that you are perhaps striving towards is how do we stratify patients and decide which therapies do we want. I think we've long struggled with this in the autoimmune disease space. I think, Jeff, you mentioned the TNF inhibitors. These have been a tremendous asset to treating autoimmunity, first with biologics and now with other approaches to disrupting the TNF signaling pathways, for example, with the JAK and JAK-STAT inhibitors, etc. But we still don't yet really have a way to predict who's going to respond to a TNF inhibitor. And certainly in some parts of the world, the best way to see who's going to respond to a TNF inhibitor is actually to put patients on a TNF inhibitor and look at their response of 4 weeks and see whether they're a responder or not. So even though we're, 3 and a bit decades in to using TNF inhibitors, we still yet don't have a way, a tool to say who's going to respond or not. So I don't think we're quite there yet.
Yeah, just my quick comment is when we do the early work, which I do not do, I do the later work obviously, but it's often interesting to me as to what is the cause and what is an epiphenomenon. And so whether it's proteomics or whether it's cells that are involved, I think of a big study that I did in eosinophilic esophagitis where we had a great result in pharmacodynamics in lowering the esophagus, and the patients in placebo did better because, who knows what's, the underlying cause of the inflammation. So I'm wary of, as in drug development, as to what's an epiphenomenon and what's actually driving disease.
Yeah. And I will focus on the target identification part, and I think that there's in the recent years, I'd say genetic technologies, if not actually genetics, high-dimensional genetic technologies have really opened up a window into the mechanisms of disease in tissues. And I think that has enabled us to identify entirely new biologies, new pathways, and new targets that are going to help us expand our ability to treat autoimmune disease inflammation in very different ways. And so I think that is another area where that application is very exciting.
Great. And do you have any questions?
Well, what is it that you think is going to be happening in the space over the next 3 years that's starting now that people might not expect, but based on the work you've done, we should be looking out for?
Yeah, I'll start. So I think we've, in the terms of drug discovery and development for autoimmunity, we have spent a lot of time and energy and have been successful in developing approaches for treating dysregulated cell-mediated immunity. So the T cell and B cell pathways, the cytokines. I think that a long ignored aspect of autoimmune disease space has been dysregulated humoral immunity, the antibody-mediated diseases. And that window has just opened up in the last 2 or 3 years, where we have actually now got some tools for treating dysregulated humoral immunity or antibody-mediated diseases. I think this is a tremendous advance for patients. We're no longer relying on the IVIG approaches, sort of a very heavy burden on patients, which historically was really the only way we could treat some of these antibody-mediated diseases. So we've got complement inhibitors. I mentioned the FcRn inhibitors. We've got IgG degraders. I think this is opening up a whole swath of approaches that we're going to see over the next decade, really thinking about new therapies for treating those patients with antibody-mediated diseases that had no option previously.
Do we get ejected at zero? Okay. Now,
You can have a quick answer.
I will say this, as a clinical developer, there's great work that's being done by folks who are finding the targets. And I think there's a ton of work, there's a ton of failure. And I would just say, as a drug developer who's had some successes in bringing drugs to market, we learn from our failures, and on this side of the drug development, we're so appreciative of the efforts of the PhDs and the folks doing their early work, because it's just so far looking out and so far reaching that it's going to help patients, which is awesome.
Yeah.
Okay, I'm going to have to cut us off, but we can talk
Sorry.
offline and we can continue the conversation. Hopefully in a year from now, a lot of things will have happened and we'll have a whole new slate of things to talk about. But thanks everybody for joining us. Thanks everyone here as well.
Thank you.